Good afternoon, everybody. I'm Harpreet Singh from University of Texas at Dallas. This is my first white conference, and it has been a good experience. I think now the terms like HIMSS, CMS, EHR, EMR make much more sense to me. Okay. Today I will be presenting paper on patient portals, and this is a joint work with Dr. Indranil Bardhan from UT Dallas and Dr. Kirksey from UT Southwestern. Most of you are aware of what patient web portals are, but let me briefly describe it. Okay? So patient web portals you can think of as online resource which combine two features. The first thing is it provides access to electronic medical records for patients, and it provides a communication channel through which patients and providers can communicate with each other on an online secure system. Okay? So this is the basic idea about patient web portals. Patients can view their medications, they can request prescription, and they can send secure messages to the physicians. Okay. So for now, why we are talking about patient web portals, for any health initiative to be successful, there are three conditions or things which need to take place. The first thing is there should be need or demand for the initiative on the patient side. Second thing is providers should be willing to adopt the initiative. And third thing is there should be enough critical mass of patients adopting it and hospitals adopting the initiative. Now for patient web portals, I think we heard this yesterday also, there is a gap between provider availability and patient demand. So what I mean by that is there was a survey in 2002 which find that 28% of the patients with specific sickness or injury were not able to get an appointment within 1 week or within 7 days of their request. And 27% patients for regular visits, they have to wait at least for 3 weeks. So 21 days they have to wait before they could get an appointment from their physicians. Now there could be many reasons for why people were not able to get timely care, and what this survey found that 33% of those cases when patients were not able to get timely care, the reason was provider availability. So there is a huge gap between patient demand and physicians' availability. And one of the solutions which people have been talking about is if we have online portals where patients can communicate with the physicians, that could somehow help us to resolve this issue. And we have found that patients are willing to use this channel. They are even willing to pay around $10 to $20 per year for using this channel. So what about physicians? I mean, this sometimes it could be true, right? What are the incentives for providers? Initially, when this initiative came up, providers were very reluctant. They thought they will be overwhelmed by the number of messages they will receive. But the initial testing, the pilot testings, when they were done, these concerns were addressed, and we have now physicians are on board and they're willing to use these patient web portals. And there have been some incentives. I think many of you are aware of meaningful use and stage 2 of meaningful use. They now require that physicians should actually use these patient web portals to engage their patients. So we have a demand, we have incentive for providers, and what we see is there is also a critical mass. Is that 70 million patients in the United States are actually using these portals, and this number is of 2008. I bet this number has increased a lot. And that 57% of hospitals have also implemented patient web portals. Okay, so this initiative is going to stay. So what do we know? What do we know about research? When we talk about this research, it speaks to HIT adoption in general and HIT adoption at patient level in particular. So what do we know? At hospital level adoption, we have seen that impact of hospital level adoption of HIT, it has a positive effect on hospital level outcomes like operational efficiencies and costs. And we have a lot of sessions regarding that. Lately there have been some research which also talk about effect of hospital level adoption on patient level outcomes like patient readmission rates. Okay? And then we talk about individual level adoption. This is where our paper is contributing to and more closely related to. The first thing that comes to mind about individual level adoption is who are the patients who are adopting it. And what the research has found is it's generally the young population. I mean, the young they define from 40 to 60 as young, so we can say it is young. And surprisingly, they find females are more likely to adopt patient web portals than males. Not only that, and they also find that female providers are likely to respond sooner to the requests which we receive from these patient web portals. So this is a very interesting result because we always think that men are more technical savvy, but what the result shows is women are actually more likely to adopt this system. And there are some more studies which talk about what kind of messages people have sent. There are studies which point out these patient web portals, when used for non-urgent acute symptoms, it has the potential to replace the outpatient visits. Okay? And then some papers which talk about physician effectiveness, and what they show is that with experience, physicians become more efficient in terms of time they take to respond to the requests. So they learn along the time. So what is still missing? We know a lot, and this is the second last session after lunch. Why we are standing here? Okay. So what is still missing is what literature has not studied is what is the effect of patient-level adoption on patient-level outcomes. There are some studies, but the results are largely inconclusive, and the literature points out the reason behind this inconclusiveness is the very small sample sizes. Most of these studies, they are related to diabetic patients, and they are from 100 to 200 patients. So there is a scope for large-scale longitudinal study to look at the effect of patient web portals on patient outcomes. And this is where our study fills in the gap. We specifically look at the effect of patient web portals on hospital admissions for congestive heart failure patients. And why we focus on congestive heart failure patients is because it's a chronic disease. And we all know in chronic disease, the self-management from the patient's perspective is very important. It's also very important to have a more smooth coordination between the physicians and patients. And we all know that hospital admissions of chronic disease patients is a major burden on the health system of the US. So that this provides an ideal context to study the effect of patient web portals on CHF failures. And as I pointed out, we know in terms of adoption that the gender and the insurance type of patients have influence on who adopts it. So we want to further study whether the effect of usage of patient web portals have any relation or how it varies with the gender or social economic characteristics like insurance type. Okay? So we have the data from patient web portals of UT Southwestern. This was implemented in 2003. As of 2013, there are 87,000 patients who are actually using it. We have panel of around 149 CHF patients from January 2010 to December 2012. We track their hospital visits, their MyChart interactions, which is a patient web portal, their socioeconomic characteristics, their outpatient visits, and non-CHF related visits. So a dependent variable is number of inpatient visits. The focal variable here we have is a dummy variable on PWP usage, whether a patient has used the portal in a particular time period or not. And then we have indicators for the insurance, which is Medicare, managed care, and we have a dummy for gender. We have control variables, and I will describe them in here. So dependent variable is count, so we have two options. We can use negative binomial regression or we can use Poisson regression. But the Poisson regression makes a strong assumption of equal mean and variance, which doesn't hold in our case, so we use negative binomial regression. We have used patient fixed effects to control for any unobserved effects at the patient level. We have used time fixed effects to control for time effects. But in this model, I think it's very important to control for patient time invariant characteristics. So patients' health can change over time, and that can have major impact on both PWP usage and the inpatient visits. To control for that, we have a number of related comorbidities in each time period. So what we are doing is we're looking at the impact of PWP usage in a previous quarter, so our time here is a quarter, to the inpatient visits in the next quarter. And we're controlling for number of comorbidities also in the previous quarter. It can also happen that over time, patients can become more proactive in managing their own care. If that happens, you will see a lot of more outpatient visits. So we do control for outpatient hospital visits in the previous period and non-CHF hospital visits. And I was having discussion with my discussion last year. The one variable we are missing here is the lagged variable related to number of inpatient visits in the previous quarter. Because if you are admitted to a hospital in the previous quarter, you will probably use PWP a lot, the web portal to interact with your physician. And it can also impact your hospital admission in the next period. And all the results which I present today, I actually tested that. Even if we include that variable, the results still hold. Okay? So let's look at the results. The base model, where we don't add any interaction of patient web portals, we find that there's a 29% reduction in hospital visits, or patients who use web portals, the hospital admissions are 29% less than the patients who use web portal. So this is a very significant result. Okay. So next we look at how the effect changes with gender. And what interestingly we find that the effect is significant for females, and there is no significant effect for males. An effect for females is actually 43%, which is a huge impact. In the next model, we also look at the interaction of patient web portals with the type of insurance they have. And what we find that for the managed care, the regular insurance like your Blue Cross Blue Shield or Delta patients, there is a significant effect around 36%, but there is no significant effect for the Medicare patients. And I was wondering why we get this result. And in the final model where we add all the interaction terms together, we see that for males, whether Medicare or managed care, the effect is insignificant. And for females, we have a significant effect. Now, so basically, it's not the type of insurance that is driving the result. It's basically the gender, male or female, which is deriving the results. To look at the specific categories which are not adopting, also the categories which are adopting and we don't see any effect, there might be some need of training to make sure that they're able to use these systems efficiently. I think we'll have questions at the end, but it's still work in progress. So I'll encourage you guys to also think about it. And if you have any concerns or any comments or suggestions, we'll really welcome that. Thank you so much.
So hi, I'm Chang-Mi Jung from Johns Hopkins Carey Business School. I'm honored to review this interesting paper, the usage of electronic patient portals and their impact on patient health outcomes, specifically for CHF patients. I am very excited. I was very excited when I first got this paper because this paper could be a punch point in the current literature in e-health. Currently in e-health, specifically in the patient portal studies, a lot of studies address the adoption of the patient, adoption by the hospitals, and this and that. But that none of them, so as far as I know, is addressing the effect of using the patient portal by the patients on their own health outcomes. So this study, especially also this is focusing on the CHF patients. A lot of studies in e-health are saying that it's very important to apply this technology to monitor and help the chronic disease patients because they are the people who need regular visits and consistent care. So this study's research question is effect of PWP, patient web portal usage on chronic patients' health outcome. And they use longitudinal data of 3 years of patient portal usage and their inpatient and outpatient visits data. And also they use a negative binomial regression. And their findings are this PWP usage leads to the reduction of their hospitalization with regard to CHF condition. Having said that in my introduction, this study fills the current gap in the literature of a patient portal and e-health. So, and also it addressed the patient portal usage and its effect on the patients with chronic condition, which is very critical and useful. It applies the appropriate method to analyze the data. I also talked to Harpreet, and he has explored a variety of different methods, and he's also going to try a further test. So I believe their approach is correct. And then their findings are interesting. This gender effect is really, really critical. Even with the different types of insurance, healthcare coverage, it's male patients do not usually have this benefit by using the PWP, but it's completely opposite for a female. And they have this unique data set that everyone will very envy and jealous. And they have a balanced patient pool. When I study my own study in e-health, I usually had a very small proportion of the patient who used the patient portal or adopted the e-health, and very, very bigger pool of the patients who never used. So it was quite challenging to do further studies, but they have a quite balanced patient pool as well. So my humble suggestions are here. Right now, they're using PWP usage, the binary value of a PWP usage as their key independent variable, key interest. But if they change this to the frequency of the usage, then that becomes how intensively the patients use and are interested in the patient portal and their own health have a different effect on their health outcome. And also, it seems that they have this category of PWP uses, such as test results review or checking what was my prior prescription. So if that was just the test results review, it might be possible that they had outpatient visit or inpatient visit prior, and this could be not just interested in taking care of it, they're just following up their previous encounters. So if they categorize the different uses, then we'll be able to find out the different effect of the different usage. Also, a lot of previous literature have mentioned that the physician information, physician characteristics are very important because they are the drivers. They are actually marketing their patients to come on board the online. So if they could control some physician information, that would be great. And then I'd like to see more elaboration regarding the patient portal site. It's a simple description of how they register, how to begin with, how this hospital is marketing or addressing how do the patients to come on board. And also more speculation on the findings. And this we already talked, and Harpreet already talked about during his presentation. So their current study data set is quarterly. So if the patient already had the CHF hospitalization in the first quarter, then it's very unlikely that they're going to have another visit next quarter. Because thinking how often the CHF hospitalization happens per year, it's very likely that they're not going to show up for in-hospitalization. But then they may have a follow-up PWP, and then next quarter 3, maybe there's no event. In that case, the effect could be reversed. And more those are just minor things. The PWP users in this study had to begin with, they had a less CHF in hospitalization, so they may have more speculation as to the difference in the patient pool. And then also this, I think if they can gather more outpatient visits and inpatient visits prior to their PWP usage, starting of the usage or enrollment, then it would be a lot better to compare before and after effect. And also theoretical framework might be a plus to the study. Thank you.
Hello, I'm Kate Burko, and I'm presenting the results of the POEM study for Dr. John Hickson. So in this presentation, I will discuss a little bit about epilepsy and its relevance to the veteran population and the VA medical centers. I'll talk about our study design and go over some results and a discussion of our outcomes. So epilepsy is a disorder that is sort of characterized by recurrent seizures, and it affects approximately 90,000 veterans. And it's expected that this number will increase due to an increase in traumatic brain injuries seen in veterans returning from Iraq and Afghanistan. As you can see in the larger graph, severe head injury has an increase in seizures after the head injury. And in a study following veterans from Vietnam, 5 years after severe head injury in Vietnam, these veterans had a 34% increase in seizures. So with that in mind, the Veterans Health Administration established the Epilepsy Centers of Excellence, which is a network of centers throughout the U.S. With the goal of not only treating veterans with epilepsy, but looking at future directions for care and research. Great. So the Epilepsy Center of Excellence in San Francisco, at the San Francisco VA, partnered with Patients Like Me to develop the POEM study, which stands for Policy for Optimal Epilepsy Management. And it was designed to assess an online health community and determine if it helps veterans with epilepsy self-manage their condition. Patients Like Me is a leading social health media site that was established in 2004. They have almost 20,000 users, and they track over 1,800 diseases, specifically many chronic illnesses. And I will now sort of go into our approach for the study, the engagement cycle on PLM, Patients Like Me, our hypothesis, methods, and results. So the engagement cycle is an important component of the Patients Like Me experience. The first step is a user enters the site and creates their health profile. The next step is they can use the site to find support from other patients with similar experiences and similar conditions. Step 3 is they can learn from the aggregated data. So for instance, a patient with epilepsy could search the site for other patients who have similar side effects from their medication or similar symptoms to see if these are normal or they can have some support from that. Step 4 would be to track their health on the site. And by tracking their symptoms, their medication adherence, possibly their side effects, this becomes all part of the aggregated data that can help other patients. And then step 5 is better self-management of their condition. So I'll just briefly run through what a patient or a user of Patients Like Me would see. They enter the site, and this is the profile page. You can see that they have the ability to enter as much or as little information about themselves as they want. It's anonymous. For instance, this user has epilepsy. They also cite migraines and osteoporosis as conditions. These are a few of the self-tracking tools the site uses. For instance, if this was an epilepsy patient, there are condition-specific tracking tools, such as the seizure meter at the bottom, which help patients to follow and document their condition. You can see they can track based on not just when they had the seizures, but how severe they were and what type of seizure. These are additional tracking tools that might help for medication adherence or managing symptoms. Another feature of the site are forums, where it acts as a way for patients to interact with each other and ask questions. For our study specifically, we had a veterans designated forum to help our participants. And then also proprietary surveys developed by Patients Like Me. So our hypothesis for this study was that the use of this online social media platform would result in improved epilepsy care for veterans, and we measured this by pre-validated patient-reported self-efficacy metrics. Our methods will be discussed here. Our inclusion criteria, they had to be a U.S. veteran, diagnosed with epilepsy or seizure disorder, and no prior patients like me usage. And these were all self-reported through the online portal. We used sort of a mixed method of recruitment. This involved patient letters and emails. Patients were often identified through the VA medical system database, phone calls, flyers, and digital advertising through Facebook ads. We collected data at baseline after 6 weeks of the site use, and then usage data from patients like me was collected continuously. And we offered an incentive for completion, which was a $50 gift card to Amazon. And so a patient who was going to enter our site or enter the study would come to this landing page where there is some educational information about the study. They would then sign up and verify everything would be digital, so they verify consent through the online portal. The example of the consent document. They would then be directed to the first set of primary outcome surveys, and I will discuss those more in depth, but these were based on a pilot study to document what would be the best way to validate our outcomes. They then participated for 6 weeks, and of importance here is we tried to make this experience as real-world and organic as possible. So the investigators at no point would contact the participants to encourage them to use the site in any way. And you can see here the different features of the site. They could connect with other veterans, so search for other individuals, join the discussions, track their condition, and then visit the VA page, which had additional educational materials. Our outcome measures were the Epilepsy Self-Efficacy Scale and the Epilepsy Self-Management Scale. And these are pre-validated questionnaires developed in the 90s by a group at Emory University. And they are basically designed to gauge a person's ability to make appropriate decision about their own care. And note that some of the questions are reverse scored. For example, the last one, when my medication is running out, I take less medication at each time. For epilepsy in particular, this would be not something to do. Okay. So here are examples of the two scales, and they look fairly similar, but they actually do measure different things, and in previous studies they track independently. The Epilepsy Self-Management Scale is measuring the frequency of a participant's self-management behavior, where the self-efficacy scale is measuring the confidence of the participant's self-knowledge. So for instance, I know that exercise is healthy for me, but how often do I actually exercise? Here are some more examples of, for instance, the self-management scale. One would be I write down how often I have seizures and when they occur. Whereas on the self-efficacy scale, something would be perhaps I can always take my seizure medication when I'm away from home, and it's a confidence level in that activity. These scales have subscales, which were our secondary outcomes for this study, and you'll notice that information management subscale of the epilepsy self-management scale is highlighted. This is what we hypothesize to have the biggest change from use of the platform, and information management pertains to things like writing down and tracking seizures. Other measures we looked at were demographic information, site utilization, and the impact of patients like me using the site's own proprietary surveys. So results. We had 453 signups with 249 eligible participants, and then 92 who completed both the pre and the post surveys. Our demographics were older and more male, which is actually more reflective of the veteran population. This somewhat surprised us. We were expecting to have a younger population reflecting younger veterans, or a population more reflective of the general patients like me population. So this suggests that older adults and older patients with chronic illness may be interested in internet-based solutions to their care. These are baseline scores for our epilepsy self-management scale. You can see the mean on the y-axis, and higher scores in medication management and seizure management, lower scores in information management. And the basic message here, these are the self-efficacy scales, is that when we go back and look at previously published literature, our baseline scores are almost statistically identical to the baseline scores of other populations who have used these scales. So we're not looking at a different population here at baseline. Our results, we saw marginal improvements in both the self-management and self-efficacy scale, and we saw a significant improvement in the information management subscale of the self-management survey. Utilization, we use these continuously, and you can see these are just basic how often people were utilizing the site. You can see that there were some people who didn't use the site at all, and then some sort of super users who used it quite a bit. So we have what we consider to be a pretty significant change in the information management subscale, and while this is statistically significant, the question becomes, what is the clinical significance here? And really, we don't know. We're using what might be considered a soft measure of these surveys. So a typical drug study would look at reduction in seizures, reduction in healthcare utilization. However, in a typical drug study, we're looking at results that would look something like this. So we have a placebo and then 3 different doses of a drug, and you're getting a reduction in seizures. And you're taking a look at, for epilepsy, a group of people who have quite a few seizures already, so perhaps 10 to 20 a month. So if you have the best outcome, you're getting a 40% reduction in seizures. But for someone having 10 seizures a month, you really have to ask the question, or the question is, what is the real world applicability of this answer? And that's someone who might be still having 6 seizures a week. And does that person go back to driving or have improved quality of life? That's a big question. And what we're looking at, so things like socialization, driving, returning to working, the question we're asking is, perhaps we don't have the biggest change or the biggest direct relationship to a clinical significance, but we do have some sort of significant change in self-management practices, and if it's very low cost or possibly free, why not put an incentive structure in place or an implementation structure in place to move this type of treatment forward? And then who is interested in this? We're in the future, we would possibly be looking at large companies that are looking to decrease their healthcare costs through self-management practices. And just to conclude, we found that digital health platforms can and should be evaluated for efficacy with academic rigor. And we were able to look at a population that might be considered a non-tracker, so individuals who wouldn't necessarily track their health care. And these are, moving forward, we would hope to take a look at these results and apply them to possibly harder measures of validation, like healthcare utilization. Thank you.
So a very nice study. One question is, why don't you look at the clinical outcome like the number of seizures every month? So that will be something wonderful to know.
So your question is, why didn't we use clinical outcomes or healthcare use outcomes? Our initial idea here was to start pretty simple. So we wanted to know if we actually saw any sort of change from using the survey. So that would be possibly the next step. It's quite a little bit more complicated to start to look at clinical outcomes, especially for a pretty complicated condition like epilepsy. but that is hopefully where we would go with this.
So one question and one comment. My question has to do with sort of the selection bias in the study. So you have people coming into the study who are opting in to use the technology. So one could argue that perhaps they're already more engaged with their health and more likely to look after themselves. So perhaps the improvement that is being observed is not necessarily a reflection of what might be observed in a population that was not so engaged with their health. So that's just one thing to consider in the design of the study. But my comment is there's probably a wealth of data in the forums, and it might be worth looking at what types of exchanges the patients are having in the 6 weeks that they're on the portal, so that you can truly try to understand what exactly is the information need and support need that is being filled by the community.
Thank you. Thank you. Yeah, and that is actually, we're looking at our utilization data now.
Thank you. I'd like to start by saying that this is the 4th year that I am attending this workshop, and the interesting observation that I have is that every year the quality of the papers presented here get better and better, and I wonder what if the quality of our healthcare system was improving with the same pace. If it was the case, then I think we wouldn't have any job very soon. So unfortunately, there are a lot of problems in the healthcare system, and we can continue to participate in white and enjoy these awesome papers. The study that I'm going to present is about the Affordable Care Act. And before I present, let me give you a brief history of why I started this project. A couple of months ago, there was a report on the negative ads spending in the United States that were attacking the Obamacare or Affordable Care Act. It was a huge number, about $450 million were spent attacking the Affordable Care Act. And then I thought, let me just write a blog for Brookings' website, and started looking at the association between these spendings and the ACA enrollment, and was seeing a positive association. The blog was very well received, and then some people were saying that what if there is endogeneity in your analysis and all those things. It was a very basic analysis, and I then, as a personal curiosity, I said, let me try to control for more variables, and let me see if there is any way that I can address the endogeneity here and see how the results look. So the motivation for this study is that, as all of us now know, over 8 million people signed up for the health insurance through Affordable Care Act. With the spike in the last days of the first open enrollment period, the number surprised everybody. Even the White House was surprised with all of these people who signed up. But the interesting point is that although this number is a big number, but the level of participation is very different among different states. While in Minnesota, only above 5% of the eligible population signed up for ACA, in other states like Vermont, about 50% of the people signed up. So the natural question that comes to mind is why there is such a huge difference in the ACA enrollment among different states. The main variable, the main dependent variable of this study is the enrollment ratio, which is basically the total number of the adults who signed up for the ACA and were between the age of 19 to 64, divided by the total number of the people who were either uninsured or had private insurance. We have excluded Medicare people, the people over 65, and also Medicaid, and also the people who had insurance through their job. So if you're uninsured or if you have a private insurance, then you are a potential consumer for the new health insurance product. And we analyzed two broad sets of variables here. The first one can generally be called economic variables. And these are the variables that you expect a rational agent to take into consideration when he or she wants to make a decision to mitigate his risk by buying health insurance. So the first one is the young invincibles. This is the big factor that everybody was talking about, and they're arguing that young people do not see a necessity of signing up for health insurance because they feel healthy and there is less healthcare risk for them to sign up. The other one is the low-income people, which were the main target population of the ACA. And the other one is the healthcare risk. This is a new variable that we have calculated ourselves, and it's mainly based on the CMS recently released data. We calculate the probability of any disease within each state and then multiply it by the average cost of treating that specific disease based on the CMS data to come up with an expected value of basically the money that you have to spend out of your own pocket if you were diagnosed with that specific disease. And we also have the ACA premium. Basically, it's the cost of the health insurance. Is the average premium of the lowest cost silver, second lowest cost silver, and the lowest cost bronze plan among different states. And finally, the private insurance premium is the alternative to the ACA. If you wanted to have insurance, then how much you should have paid if you wanted to buy it through other areas. So all of these data is publicly available. It's coming from various sources, including Kaiser Family Foundation, CMS, HHS, and other sources. All of these, the sources and the links to the websites, I have provided them in the full article, and it's available online. You can get it. The other factors are the political factors. And although many of us tend to assume that people only go with the pure utility of a new development and decide whether to buy or whether to adopt it or not, only based on the utility that it has for them, it's not the case here. As the recent surveys show, many right-wingers have been covered through Obamacare. They love Obamacare. They love the security, the healthcare security that it provides for them. But when they ask them, are you going to vote Democrat next year, they say no. So although a product may be adopted by them, they may like it, the political and emotional and religious point of views play a role here. So we control for a set of factors. The first one is the liberal voters. It's the percentage of the population who voted for Obama in 2012. Catholic Church members, the reason that we consider this variable is because of the problems that the Catholic Church had with the ACA with regards to the laws about Planned Parenthood and all those stuff. Education, we just controlled for that. Anti-ACA ads is the main independent variable that I was interested to see its results. And then we have the state-run exchanges. It's equal to 1 if the state decided to run its own exchange, and 0 if it was run by the federal government. And finally, we have Medicaid expansion and the insurance cancellations. Medicaid expansion is again equal to 1 if the state agreed to expand this Medicaid program, and the insurance cancellation is basically the total number of canceled insurances, canceled private insurances. Again, if you remember, it was a huge controversial issue. We're saying that the president was saying that you can keep your insurance, and now all of these canceled insurances. We were thinking that if there are more canceled insurances, people will be furious with the administration, and there will be less adoption. The controls and basically the instruments that I'm using in this study are the uninsured females and Latinos. Again, I think I talked about education previously, but there are a couple of cute instrumental variables that we have here, and they are basically the competitive index in the midterm elections in the House and Senate. And their rationale behind including them is that we all know the spendings on the negative ads is not a random variable. It's been driven by other variables. And the major variables that drive the amount of spendings on the negative ads is the midterm elections. So in the states where there is going to be a midterm election, especially if there is a Democrat incumbent competing in the midterm election, then there would be a lot of negative ads attacking Obamacare, not to deter the people to sign up for Obamacare, but just as a means of attacking the political opponent. So these two we used as our main instrumental variables. And then the econometric specification is a very basic one. We have a logistic regression in which we consider the effect of all of these variables that I talked about on the proportion of the people who sign up for ACA in each state. And there are three endogenous variables. I just talked about one of them here. The main and the most important one, which is the anti-ACA ads. We basically run a control function method. We do not run a usual two-stage least squares in the instrumental variable method here because we have a nonlinear specification. It's a logit function. So it's a slightly different. What we do is that we regress the anti-ACA ads on a set of variables, including the House competitive index and the Senate competitive index. But we keep the error term, which here is the U of the log of anti-ACA ads, and then when we consider it as an independent variable in the final logit regression, and instead of having the estimated value of ACA ads, we keep the original ACA ads here. Again, I have discussed the econometric details in the main paper. There are a bunch of interesting things. First of all is that the young invincibles are not a major problem here. If a state has a lot of young people, it's going to have a lower participation rate, but it's not as that much it's not as that large. And before I continue to talk more about these are the marginal effect at means. So I use this method because it's much easier to interpret the results, and I don't have to use the log or log odds on those stuff. So everything is interpreted in terms of the probability or the percentage. The other interesting things that we can see here is that still the more you spend on anti-ACA ads, the more people going to sign up. There are two reasons that I can cite for this observation. The first one is that when you talk about something, no matter if you're attacking it or if you're appraising it, it's going to create awareness. So people going to know that there is something about ACA, there is something called Obamacare, supposedly it's a bad thing, let me go and search for it and see what it is. And then they see it, although they hate Obamacare, but they sign up for ACA. The second thing is that it's a subsidized product. So you're going to get health insurance, which with a much lower cost that you can get. And there is a lot of uncertainty about the continuity of this service. So if a person is living in a state where there is a lot of anti-ACA ads, and they're always talking about repealing Obamacare, send us to Senate, we promise that we will stop this process, then that individual person will have a higher perception about the chances that this service is going to be discontinued. So if a person is living in, I don't know, Texas, probably he will he will put higher chances on Obamacare being repealed in the next elections than a person who is living in New York. So since he thinks that there is a higher chance that this service is going to discontinue very soon, then he will have a higher incentive to go and sign up for it as long as it remains and it's available. This paper is a working paper, and it has a lot of problems. The first one is that there is a major issue with the ecological fallacy here. I don't know why I wrote analysis. It's analysis. The problem is that we are only having data at the state level. I would have loved if I had the individual level data, but I don't have it, and I don't know if it's available anywhere out there. So it would be a nice development if we could collect individual level data and do the same analysis at the individual level rather than the state level. And finally, the conclusion is that at least based on the state level data, there is no such thing as bad publicity. Thank you.
All right, so I will serve as the discussant on this paper. First, I thoroughly enjoyed reading this paper. It was very interesting. It's on a timely topic of Affordable Care Act enrollment. So to summarize this paper, it was trying to identify the drivers and inhibitors of ACA enrollment. It's essentially like technology adoption along those lines, but by focusing on factors beyond the commonly studied variables such as religious factors, economic factors, political characteristics. The study tries to extend our knowledge. It tries to go beyond what's already known. In terms of data and methodology, the data seems pretty rich. It's come from various sources like the Kaiser Family Foundation, CMS, HHS, a wide range of sources the data has been pulled from, and that makes it pretty rich. They are able to look beyond individual factors like political affiliation, the church that they go to, things like that. And the study has employed multivariate logistic regression, although one would expect a two-stage least squares type analysis. The key findings in this paper were the anti-AC advertisements seem to increase the enrollment ratio, counter to what one would expect. The more a person sees anti-AC advertisements, the more they are likely to sign up for it. And the authors argue that this is by way of raising the awareness about the existence of ACA. Also, another key finding that I found interesting is with increases in Catholic Church adherence in a state, the ACA enrollment actually decreases. And finally, the study also found, which is of importance to state-level policymakers, that state-operated insurance marketplaces experience slightly higher enrollment ratio compared to the federally administered ACA programs, which is pretty interesting, which probably suggests that decentralized ways of spreading these programs may be a better way than federally administered ACA programs. On to some comments and suggestions on the paper. As I was reading through this paper, I was more interested to know why. Like, there were a lot of interesting findings, but I would be more happy. I would have been more happier to know why these were found. Like, what was the theory behind? What was the rationale behind? But I guess because it's a work in progress, maybe there was not as much rich theory in the paper. But still, going forward, for example, one of the findings in the paper was that higher ACA premiums lead to higher enrollment, but there wasn't a lot of explanation given to why it is. So this is just an example of what could be considered going forward, like giving some explanation, giving some rationale, maybe hypothesizing upfront may be a good way to go about. Also, other literature bases that could possibly be used to explain could be the prospect theory or the message framing literature, which talks about how positively framed messages or negatively framed messages could affect user behavior. So, especially given the fact that negative ads seem to increase enrollment ratio, one way to go about could be to rely on the prospect theory or the message framing literature base to give a further rich theorizing. Also, other theories like the health belief model, the production motivation theory could be used to further support the argument. For example, one could argue the health risk that the paper talks about. The health risk could be in terms of the health belief model the person believes the health to be in, or their inclination to be defensive or be productive upfront, even if they don't have any illness. So these are some issues that the paper could look going forward. Secondly, this study didn't seem to really position itself on top of prior research, although it's pretty interesting. I couldn't see what was the literature base it was building off of. So one good idea may be to situate this in the larger body of research and try to show how it incrementally progresses our knowledge of adoption and inhibition. For example, recent research on citizen adoption of e-services could be one such stream of literature to build off of, because this is essentially a government-administered service. The third thing is, why only consider, and the paper did mention about, even Nia mentioned it in the course of presentation, that individual level factors were not studied in this paper, for the data was not available. But going forward, why only consider only the political, religious, and economic characteristics of the state? Because essentially these could be even at the individual level. Because essentially ACA enrollment is an individual level decision making. It's the individual who signs up for these plans. So it might probably make more sense to collect data at the individual level and see the willingness to join. Also, any individual differences such as risk-taking or innovativeness, these could play a role. So something like the paper, if the data is available, going forward could possibly study how the individual level characteristics could affect ACA enrollment. Also, going further beyond, the paper could study the multi-level effect of how the state level characteristics and the individual level characteristics the interplay between the two, and how this could in turn affect the adoption. So these were some of the comments I had on the paper, and overall it was pretty interesting. Let's open the floor now for some questions.
So for patient portals, if I'm a health system, CIO, CEO, I want to invest in this type of technology, what lessons can I take from your study and how to do that the best?
So, can you repeat your question once more?
So so from your work on patient portals and how they impact patient health outcomes, so if I'm investing in a patient portal solution, what recommendations would you have for me?
So what we found is that the effect is very specific to certain types of people who are adopting the system, and also when they adopt it, it is very specific categories which we find the effect as to be significant. So if you are implementing the solution, there might be a need to motivate other people to adopt the system, and there might be need for training also in terms of like the Medicare patients, they don't find any significant effect. But there might be need to train those patients to use the system more effectively.
I have a question for Harpreet. Did you try to control some of the unobserved factors that could both affect, for example, how often you interact with your physician through the portal, and also affect your frequency or likelihood of being sick again? And
yeah, so we have the data on the outpatient visits, like how frequently you visit your physicians, and we do control for that.
Yes, so regarding the patient portal study, did you get a chance to look at readmissions after 30 days of being discharged?
So we haven't done that, but I think we have the data and we can actually look at the readmissions. Right now we just focused on the number of admissions, but yeah, it's a relevant thing, we can look at readmissions.
Question.
I have the microphone. So again, regarding your study, there was a very interesting variable there, which was gender, which we are used to see gender and age and other patient demographics as control variables, especially in the IS papers. But it's a totally different creature when you're working on the healthcare IS. And to give you another example of how important it is, in other contexts, a very, very similar context like yours, we also see that there is a significant difference between men and women regarding the use of information technology in the healthcare. And I think in addition to the theories that you cited, the other theories that can help us explain these differences is that, first of all, it's a known fact that women consider the healthcare risks as more eminent and more seriously. So they are more conscious about their health. They they care a lot more than men about their health. And I know my father always said, "I'm fine." My mother was always trying to take him to the doctor. So this is one thing. So women perceive a higher utility of using these systems to improve their health because they're more concerned about their health. And the other thing, especially in the patient portal case, there is always a concern for privacy. You know, what happens if I sign up to the system and then somebody hacks it? The privacy concerns for men are much higher. So women are more willing to open up and talk about these things. So they have lower concerns for privacy. And if you consider these two things together, they perceive a higher utility of adopting these systems, and at the same time they have a lower concern than men for their privacy. Then that's one of the explanations that you see higher rate of adoption and usage of these kind of systems among women than men.
A question for Kate. So in the POEM study, do you look at the gender difference between men and women about the effect on that?
We actually didn't look at a gender difference. We had predominantly men, I think 80% male. Yeah. It was reflective of the veteran population.
Right. Also, do you look at the dropout, during this intervention? That is, people to stop using patients like me.
Yeah. So we had 92 completers who completed the second survey, which looks fairly low, starting from 250 almost. However, if we review the literature, that's actually a fairly normal dropout rate for an internet-based intervention study.
Thank you very much.